Next slide, please. Closed captioning has been enabled for this event. Click on the closed captioning button at the bottom of your Zoom window to turn on subtitles. If you need to change the language for subtitles, click the caret to the right of the button and choose your preferred language. If you are having technical difficulties, please direct message Angelina Callis in the chat for help. Next slide, please. Okay, today's agenda, we will start by going over the purpose and intended outcomes of the BHA Town Hall meetings. We then have a BHA update for you all, followed by a tech engagement presentation on provider administrative burden. Next up will be an update on CYF priorities and programming. And then we will adjourn, as well as talk about how you can continue to be engaged and get involved with the BHA. Quick reminder, town halls are not intended to take place of targeted stakeholder engagement opportunities. Town halls are a space where we ask for your input and feedback on the broad topics we cover each month. All sessions are open to the public, partners, and community. We welcome your input on future session topics. Please utilize the Q&A feature or chat to submit any comments or questions during the town hall. We will record the town halls and post them on the BHA website, along with any documentation shared during the sessions. Next slide, please. Okay, for BHA updates, I'm excited to introduce you all to Michelle Barnes, our interim commissioner of the BHA. Welcome, Michelle, and thank you for being here with us today.
You are so welcome. Excuse me. Excuse me. I hope everyone can hear me all right. So let me start by just introducing myself. My name is Michelle Barnes, she, her, hers, and I am just been asked to step in as the interim BHA commissioner. I've been in this role full-time as of Monday, so we're just on early days, but I'm not new to behavioral health. Back in 2019, when Governor Polis set up a behavioral health task force, he asked me to chair it, and I spent over 2 years working with Summer Gathercole, for one, who was made all the magic happen there. We worked with a task force of 100 people across the state of Colorado to find out what their needs were in terms of behavioral health and what they needed from the state and the system to be able to live their best lives. They were heartbreaking conversations. I spent many, many weeks on the road over the course of 3 years, listening, and together, as did the other task force members, and together we came up with a roadmap for behavioral health reform in Colorado. It was approved and endorsed by the governor, and one of the key recommendations in that report was to form a behavioral health administration, and we did. At that point, Governor Polis hired a commissioner of behavioral health who has led this organization for the last 14 months. And I went back to my day job, which was running the Colorado Department of Human Services. At Human Services, in addition to running this 2 state mental hospitals, we also oversaw the child welfare system, the adult protective services system, the juvenile justice system, economic assistance programs for Coloradans. So a lot of different focus that was all on helping people in need. We called ourselves, our vision was to help Coloradans thrive through bold and innovative health and human services. So I have come over in the interim to oversee the BHA, and I am not a candidate for the permanent role. There will be a search headed by the governor to identify that person, but until then, I'm here, and couldn't tell you how excited I am to be here. As I said, I'm really completely dedicated and on board with what the BHA is about, why we formed it, and how it's going to make the lives better for Coloradans in every corner of the state. I'm absolutely committed to staying with the mission and vision and purpose of the BHA. I have no intention of changing any of that. This organization was founded with so much stakeholder and so much intention about purpose that that's going to live on with no rearview mirror looking at that. I'm also focused on executing against the strategic plan that the BHA set out. I think it was published not very long ago, and it's really excellent. And it really lays out the priorities that the BHA is going to take in order to get to this equitable, accessible, and system that works for all Coloradans and their behavioral health needs. So none of that is changing. I'm fully committed to it. And so I don't think you'll see a big shift in the work of the BHA. I do know, and I've already seen in the chat, there's a lot of questions about why there was a transition and why we have an interim commissioner. And I will tell you, that's not something I'm able to discuss, or it's frankly not something anyone at the BHA has visibility into. That's not our business. We were here to run the BHA. The decisions on staffing of all cabinet posts sits with the governor. And so I don't want to speculate, and I don't want you to be disappointed, but I really can't answer more than to tell you I'm here and I'm excited and I'm going to work with you to do good work. So a couple things I just want to stay off the top. As most of you know, the BHA, it operates as an independent organization. However, there's a limit in the state constitution as to how many not cabinet positions, how many departments the governor can have. That number is 20. When the BHA was formed, he was already at 20. So BHA is set up to be housed within Colorado Department of Human Services, but to execute independently. So why that matters, it means the BHA is getting a lot of our back office support from CDHS. It's getting a lot of resources and advice on it, but decision-making sits ultimately with the BHA. And that's not going to change. The mission, vision, values is not going to change. And I'm really looking forward to collaborating with a lot of you guys on our work. I've already had quite a few calls already and meetings with people, and I'm welcome to have continue that. So if you have a question or want to call with an issue, please reach out, and I'll put my my email in the chat so you all have it. So my intention really is to bring stability and really focus everybody on the top priorities that people, Coloradans, told us they had, as well as the legislature funded us to do. You know, interesting thing when you're a state entity, you have to go get funding to do any of your initiatives from the Joint Budget Committee and the legislature, and we got a lot of funding, and they were very clear on where they wanted us to prioritize. And those will be the initiatives that we're really focused on getting launched and done in a way that's inclusive and created with all of you. One example of that, I will say, is that the BHA was tasked with forming BHASOs, Behavioral Health Administrative Service Organizations, and establishing those and doing rules around it. That is a huge task, a huge task. And as I'm talking to people, I'm realizing we don't all even agree and understand what a BHASO is. So you can imagine if we're going from a place where we don't even all, not BHA employees, but stakeholders and people, we need to just get out there and explain to people what a BHASO is and why it matters and what it's going to do for them, and hear what's important and hear what's not important. And according to statute, we were asked to have that set up by have the rules on the BHASO set up. Let me get the dates right. Set up in a year. That's not going to happen. It was too big a task. I will say the BHA staff work night and day. I've never seen such hardworking people. but there's no way we'll be able to make that deadline. So as we're on this call, there's a group of people over working with the legislature to get an extension on the BHAs, which means we'd have more time this summer for stakeholdering, community engagement, coming to your communities, and being able to talk about what you need in a BHA. We don't know if it's going to be approved. We might hear while we're on this call, but we are asking for an extension to give us significantly more time to do stakeholdering. So I hope that feels good, because I know a lot of people are concerned about the fact that so many decisions were being made, right now and quickly, and we acknowledge we need more time. So that's an example of one of the changes that you'll see is really giving this amazing staff time to do the work that they need to do, and going to the legislature and asking for an extension. So with that, I will pause. I don't know how you want to do this. If anyone has any questions for me, just put them in the chat and I'll reply to them as the session goes on. I'm open to your questions. I'm open to emails. I'm open to any way that you feel best to engage. But I am here and I am fully committed to the success of the BHA. So I'll pause there. Who's up, Megan?
Thank you, Michelle, for that introduction and presentation. Angelina, can you share the slides again?
Yes, and I want to note, I think Zoom has some trickiness here for our panelists. If you would be willing to actually turn your video off while we're presenting, and if you're not speaking, that would be greatly appreciated, because then our ASL interpreter has a chance to have their video on, and I believe folks should be able to pin them if their video's on. So let's try that. I appreciate everybody's patience. Thank you.
Angelina, if we're speaking, should we keep our cameras on?
Yeah, that should be fine. And folks in the chat, please let me know if it's still not working.
Okay, I think we are ready for the next slide. And I'm excited to introduce Alex Orlov, Abigail Fisher, and Mark Gammon with the Health Information Technology team. They have prepared a lovely presentation for you all on tech engagement on administrative burden. Wow. So I will go ahead and turn my camera off and hand the floor over to you all.
Thanks, Megan. Hi, everyone. My name is Abigail Fisher, she, her pronouns, and I'm a human-centered designer with the Behavioral Health Administration focused on provider technology. Some of y'all might have seen me before. I've presented at office hours, as well as these engagements like provider convenings and town halls. And I'm really excited to tell you about another opportunity we have coming up to engage with the BHA technology team. But just a little bit of context setting before I jump in. When I say human-centered designer, that can be a little bit of a jargon-laden term. So said simply, thanks, Steph. Human-centered design is a mindset, skill set, and process that helps put people and their needs at the center of our work. We like to use a word called co-design when we're talking about design at the BHA in regards to technology. And really what that is grounded in is we're designing with and not for folks. So we use creative and participatory methods to redistribute power to those most impacted by systems, solutions, and technology. And so for a project like administrative burden, all of y'all on the call would be the folks that are most impacted by that technology system. So this presentation is going to be about how we're thinking about designing with you and not for you in regards to this specific piece of research. And I'll quickly introduce my colleagues. Mark will be talking with y'all in just a little bit. But Mark Gammon is another human-centered designer focused on data systems. And Alex Orlov, she, her pronouns, is another human-centered designer focused on the public domain. So technology systems like OwnPath. You can proceed to the next slide. So what do I mean when I say administrative burden? Although I'm sure that is very intuitive to everybody on the call. In short, it refers to the time, effort, and resources required to comply with administrative tasks, rules, regulations, and procedures. It can be tied to payment with the state. And really at the end of the day, it can impact individuals who have to navigate the complex processes to access services and receive care. And we know that at the Behavioral Health Administration, it's written in our priorities that reducing administrative burden is a priority. That was a redundant sentence, but y'all get it. Next slide, please. So said even more simply, what does this really mean for human beings? We like to think about it in the sense that, you know, every minute of administrative burden reduces and replaces care time with people seeking care. We know that there's already a behavioral health staffing crisis, and we know that administrative burden impacts that already strained system. And this, almost most importantly to me, is that the discrepancy between how it feels to receive public and private care is unacceptable and ultimately punishes people seeking care through public supports and services. And so we're really looking to tackle that truth through this specific vector with this project. Next slide, please. So administrative burden is an enormous task and is far too much to do in the couple of month time frame that we're focusing on here. But we're going to take a small bite out of it and really focus on the question, how might we better understand and improve the actions, actors, processes, redundancies, and opportunities that exist for a BHA provider's daily routine in regards to data and information collection with a specific eye towards CCAR and day codes. So we know that a couple of years ago, there was really amazing work done, probably with a lot of y'all on the call right now, in a project called Compass that sought to unify and reduce CCAR and day codes into a single system. It's been a few years, so part of this work will be to gut check all of that work that has been done and really respect all the conversations that many of y'all have had around this project, make sure that all of that is up to date, and then make additional recommendations about how to move this work forward in short order. We have a hand up, so when we take a break, we need to get to that. Okay, Angelina, should I get through the rest of the slides and then do that?
Yes, let's finish this
right.
section and then we'll pause.
Sounds great. All right, next slide. So in terms of goals, there's sort of tactical short-term goals and then longer strategic goals that we have in mind. So first and foremost, we really need to understand, you know, what are the types of data and information mandates facilitated by the BHA? What do those look and feel like? That may include legislative, fiscal timelines, client interaction requirements, and other rules and regulations. Then launching off of that, we really need to understand how to move the system forward, improving data quality and reducing redundancies. A part of that is, you know, getting really down to what tech system are we going to be using? How does that interact with providers' existing technological ecosystems? And how might we improve processes for data collection? And this part is also exciting. We really want to better understand how providers could benefit from the data that is being collected by the BHA and shared back to them. We know that data in aggregate can be really powerful in describing like how we are caring for folks and what trends we see. So we want to make sure that we're uncovering that as well. Next slide, please. And then we have this long-term goal. So like I mentioned, administrative burden is sort of a huge task. We're taking a small bite by focusing on CCAR and day codes, but we imagine we're going to uncover a lot of insights around other, processes and redundancies and types of data and information collection. So we want to start to build a repository of sort of a larger understanding of like what it means to be a provider associated with the BHA, and really identify areas for further research, further recommendations, and follow-up. So that's kind of our larger long-term goal. Next slide, please. All right, I'm going to turn it over to Mark and start to answer some of the questions in the chat. Thank y'all.
Okay, thanks, Abigail. Can everyone hear me okay, I hope? Just a quick introduction. My name is Mark Gammon, he, him pronouns, and I am also a human-centered designer and researcher in our BHealth team, which is focused on our data. And so Abigail and I have been collaborating on this work, and I'm going to take the last few slides here and just talk a little bit about some of the early insights we've had from work we've been doing to lay the foundation. So we've been doing a lot of internal state interviews with our staff and wanted to just share a few highlights. All of these are insights that we will continue to explore throughout the work, and we hope to move these forward and sort of check these. But definitely understanding that tech systems, reports, assessments, all of those things are a task to sort of understand in and of themselves. They're CCAR the system, CCAR the report, CCAR the assessment. So we're identifying a lot of those kinds of things and wanting to make sure that we recognize the complexity here. Also that we've identified that federal reporting requirements seem to rarely change. Most of the changes related to CCAR and day codes are driven by the state. As Abigail mentioned, we've been talking about the Compass project, and so far we've heard that folks think the Compass core data model is still fairly fundamentally sound. But again, that's something that we want to continue to test and evaluate through this project. We recognize that there are a wide range of technological capabilities and resourcing across the providers. And so we want to keep that in mind as we think about recommendations for addressing burden. We know that a lot of the knowledge about the data reporting and requirements is sort of ad hoc, and often that comes from legacy or institutional knowledge, through colleagues, through internal workflows, and those kinds of things. We want to think about how we can improve upon that, if that's training, documentation, other ways that we can help impact that as well. We've identified that there's a sense that there's not a lot of clarity about the value of CCAR and day codes for providers. And then, as Abigail mentioned earlier, we've definitely recognized that reporting is siloed right now and that there's not a lot of accessibility by providers to the data that they report. So clearly these are things that have come up. They're not all of the things we've identified so far, but it's a slice of some of the insights we've been gathering. And again, we'll continue to test this and explore this work as we move forward. Next slide. Just going to walk us through a couple of kind of logistic things where we're at with this process. We've been engaging for the last few weeks on our foundation setting, doing a lot of these internal interviews. We're moving towards our research planning and execution. So starting to identify providers to work with. We're anticipating conducting some interviews and intending on doing a couple of site visits as well. We think that's important. I can talk a little bit more about that later. But just in terms of our timeline, we're moving into that set of work. We'll be doing more engagement with all of you all in the coming weeks. And then we'll be spending the last part of this engagement doing synthesis, developing outcomes and recommendations, and doing a lot of refinement and sharing out of all of that information, including with everyone here as well. Next slide. And so I mentioned that we're getting ready to do some interviews and site visits. So that is going to be our two primary methods for gathering data and insights. We're anticipating doing hopefully between 10 to 15 interviews with a wide variety of providers. We're in the engagement of recruiting those providers now, folks who are users of CCAR and day codes, and we'll be not only meeting and talking with folks, but also wanting to collect any kinds of materials and resources from providers that would help give insights about their workflows, processes, all of that, so that we can gain as much information as we can outside of just a single interview. We'd like to do a couple of site visits, and we're hoping we can do not just one-off site visits, but a couple of days with some sites. We really feel like it's important to gather information within the context. So if we can actually be on site, and we recognize that we would need to work through exactly what the logistics of that looks like, but we'd like to be there and experience and observe what it looks like to move through these reporting processes. The last thing we're thinking about doing is we'd like to better identify and get a sense of tech systems and tech capabilities. I think we have a lot of that information already, but we may initiate a survey if we need to try to gather a little bit more information about EHR use, staff on site, those kinds of things that can help give us information about the technology systems and capabilities across providers. Again, as Abigail mentioned at the top there, sign up for office hours. We'll be doing regular engagement activities there. So this is not the only opportunity to have input into this engagement. There'll be lots of opportunities beyond just the interviews and site visits we're doing now. And the next slide, please. Finally, just a little bit of information. We're trying to be intentional about getting broad and inclusive representation of provider types. So we're thinking a lot about variability in technology, both technology staff size, if there's technology staff available, how folks enter CCAR and day codes using batch entry versus manual uploads through our systems, EHR types, if folks have EHRs, and things like the roles and staffs engaged in CCAR and day codes. So that could be administrative, clinicians, leadership, all kinds of roles. And then also thinking just about other categories in general, the different services types provided, different communities that are served, size and settings, geography. So we're trying to be as inclusive as we can across these representational vectors. And next slide, please. Great. I think that takes us to our last slide and room for Q&A.
Mark, I know lots of Abigail's in the chat answering questions. We were not going to do live Q&A today. So if you can pop into the chat and scroll up and see if there's some things you can help us address there, that would be great.
Will do. Thank you.
Thanks.
Thank you so much, Mark and Abigail, for a wonderful presentation. And I see there has been quite a bit of dialogue in the chat, so thank you for your great questions. And we will now move on to a presentation on child, youth, and family priorities and updates with Chris Meyer. Thank you, Chris.
Good afternoon, everybody, and thank you, Megan. My name is Chris Meyer, and I go by she, her, hers. I am the Senior Advisor for Children, Youth, and Families here at the BHA, and I apologize for my froggy voice as there are germs in my house. So I just wanted to present a few slides focusing on the work within the BHA for Children, Youth, and Family priorities. As mentioned earlier, the BHA strategic plan was released at the end of January. And so within the strategic plan has elements focused on children, youth, and family priorities. And so just at a high level, I'd like to just go over these priorities with you all today. And so our first priority within the BHA and the strategic plan is focusing to elevate children, youth, and family needs. Looking at the unique needs developmentally of children and youth, as well as the unique needs of families within the behavioral health system here in Colorado, making sure that the needs of children and youth and their families and caregivers are elevated to ensure that there is appropriate representation for services within the continuum of care. Also, as we look at the next piece, developing quality standards for children, youth, and families that are receiving care within the behavioral health system and providers within Colorado. Our next priority is the creation of a no wrong door approach and making sure that families and young people, as well as our providers and child and youth serving systems and community, are aware of the access points for the children and youth, as oftentimes from feedback and stakeholdering from the Behavioral Health Task Force, we heard that is often very confusing for all Coloradans to find that point of access, especially families looking for care for their children or youth. We are also going to be focused on increasing early childhood investments, looking at our youngest Coloradans and assessing where generational impact can be made in cross-agency investments in early childhood, as well as for pregnant, postpartum, and parenting people. Finally, we want to enhance telehealth services for children and young people and make sure that families as well as the people of Colorado are aware of telehealth services here in Colorado. Currently, we are providing iMatter as a telehealth service and continuing to evaluate the effectiveness and continued reach for children and youth that are in need of rapid mental health response. Next slide, please. These next 3 slides are going to be focused on, or 4 slides, I apologize, will be focused on child, youth, and family services. And so the first slide is going to be focusing on our Colorado crisis services. And so we, as many of you are aware, have a variety of Colorado crisis services that is administered or overseen by the Behavioral Health Administration and operationalized through Rocky Mountain Crisis Partners and our administrative service organizations. And so our Colorado Crisis Services, as many of you all know, we have our hotline. We also have our text line. And then we also have available our walk-in clinics. And so we have noticed that our text line is utilized by young people very frequently. We've also held some focus groups with young people within Colorado who've utilized our crisis services as we look to improve access, improve trust, and the approachability for Colorado crisis services. As many of y'all know, we launched the BHA in Colorado as one of the leading states, launching 988 in July. And so this is our new national 3-digit hotline for emergency response for mental health crises. We're also seeing the utilization of almost 50% of young people utilizing this line. And so we are also engaging with young people of learning more messaging around our 988 and how to improve trust with these services for young people. Finally, a newer program that we put a press release out at the end around the holiday season in December is our crisis resolution teams. These teams are a comprehensive team that is working with children and young people and their families that are experiencing a behavioral health crisis or challenge and would benefit from intensive and short-term in-home and community-based services that would link them to the ongoing services that they would need within their community. Also, just focusing on crisis resolution services, these include a needs assessment, service planning, care coordination, crisis management, peer support, family skill building, individual and family therapy, psychiatry and medication management. Really, our crisis resolution teams are aiming to avoid hospital admission whenever possible and wrapping services around a family in an effective and customized manner. Next slide. I mentioned iMatter, but to also highlight iMatter as our rapid mental health response, offering up to 6 sessions for families, children up to 18 and including 21 if they are receiving special education. These services are predominantly provided via telehealth services with some options for in-person and providing not just the rapid mental health response, but also triage to either longer term services and supports, or whether there's other community-based or social services that would benefit the child, young person, or family. Next, I'm going to highlight our Tough as a Mother campaign and directory. And so as a mother myself, just wanting to acknowledge that being a mother is hard and being a mom is tough, and so are you. And so really, this program is really supporting our moms and caregivers that are struggling with alcohol or other drugs to cope with stress, and just wanting to reassure that people, you are not alone, and others in your network, they are not alone. And so this is a directory that will provide information about what to expect for treatment, how to find treatment near you, how to find services that also can accommodate dependent children and provide while providing treatment. So this is a very important resource and important to share. Next slide, please. Our next service quickly to cover, which is very near and dear to my heart, is high fidelity wraparound. This is an evidence-based care coordination model focusing on an individualized and family-driven and youth-guided plan to help support families with complex, whether that is mental health and or medical or multiple diagnoses, to really help the various coordinate the various services and supports that are in a family's life. Ultimately, through the phases of wraparound, families are at the end of the service leading their family meetings and moving towards their celebration of transition. For more information and services, you can find more information at the link or coactcolorado.org. Next, an important service just to highlight is for those that are experiencing for deaf and hard of hearing Coloradans. And so led by one of our partners, WellPower, the Colorado Commission for Deaf of Hard of Hearing is our Colorado Daylight Partnership. And so when thinking about cultural and linguistic and disability services, this is a critical one to include and not to be overlooked. And so there's more information to make sure that there are adequate services for those that are experiencing deaf and hard of hearing. Next slide, please. Our last two services that I will highlight today, and I just want to encourage people to go to the bhacolorado.org, and under Children, Youth, and Family Services, you can find more information about all of the services that have been provided today. Also importantly is our Ascent Colorado program, as some know as first episode psychosis, and in Colorado is known as Ascent, is a holistic community-based approach to mental wellness and provides treatment for our youth and young adults 15 to 29 who are experiencing the onset of first episode psychosis or psychotic spectrum illness. And so, excuse me, programs meet with a comprehensive team that includes mental health staff as well as peer support, as well as working with the family to wrap services around them for an extended period of time, up to 3 years, to guide them towards stability and independence in their own life. Finally, the Child and Youth Mental Health Treatment Act, otherwise known as a long acronym of CYMHTA, allows families to access mental health treatment for their child or youth as an alternative to getting involved in the child welfare system through a dependency and neglect action. This is a really important program that has evolved over the years, and so CYMHTA funding can be available when no other appropriate funding sources for treatment, such as private insurance. And so we have a great state administrator here at the BHA who's happy to answer any questions. And again, if you're in need of any information about the services I have presented, please go to the BHA website and look for Child, Youth, and Family Services. Thank you.
Thank you so much, Chris. Valuable information, very exciting, all of the things happening for children, youth, and families. Okay, next up is some information on our next town hall. So our next town hall will be Wednesday, May 24th from 3 to 4 p.m. And some of the topics we may address at that town hall or at the later town hall will be a legislative update, behavioral health ecosystem, and whole person health defined. We will also provide time to answer any questions from this town hall that we did not get to today. Next slide, please. So here's some reminders of how you can get involved with the BHA. If you have not done so already, you can subscribe to the BHA's monthly newsletter. There's also an open feedback form on the BHA website. Additionally, there's a BHA events calendar that is open to the public, and this contains things like the monthly provider and crisis convening, the monthly BHA Town Hall meetings, the BHA Advisory Council meetings, and the Behavioral Health Planning and Advisory Council. So we encourage you also to reach out and let us know what are additional topics you would like to see highlighted in future town halls for the BHA. Feel free to put them in the chat or connect with us directly.
And Megan, I know we're getting to the end here, so I'm just going to remind folks who presented to please not just look in the chat, but also look in the Q&A section of Zoom. We have a couple unanswered questions in there as well.
Thank you for that reminder, Angelina. So on this next slide, you can scan with your phone to stay connected with the BHA. And we will leave this open for a few minutes while folks are answering questions in the chat.
I'm gonna stop sharing, Megan, since we're at the end of the slide, but that way folks can continue to respond to questions in the Q&A in the chat. And like Megan said, we'll stay on so that our presenters have a chance to answer and respond to those questions. If folks are interested in seeing those responses, please also continue to stay on, but we're wrapped up for today.
Thank you, Angelina, and thank you all for your time and attention today. Thank you for being dedicated to learning more about the work that the BHA is doing. We're excited that you all could join us.
Special shout out and thank you to our interpreters. For folks who were trying to pin them, I promise I'm going to do some Zoom training and get it figured out so that next time it hopefully goes more smoothly. I appreciate your patience. Abigail, I just want to call out for you. We had a participant add their email, into the Q&A. So if maybe you want to copy that and then reach out to them directly, that would be great. Thank you.